Good afternoon, everyone. I am Rahul Gosain,
And I am Rohit Gosain.
and we are Oncology Brothers. Today, we're joined by Dr. Rachna Shroff, who is a practicing medical oncologist and a division chief of hematology and oncology and associate dean of clinical and translational research at the University of Arizona Cancer Center. In a discussion with Dr. Shroff, we're hoping to focus on three clinically relevant studies in GI malignancies that were presented at ESMO 2022 and how these studies will impact our practice in the community. Let us welcome Dr. Rachna Shroff.
Thank you so much for having me. I look forward to chatting with you all.
Thank you, Dr. Shroff, for being here with us today. Our goal with this discussion is to keep our community oncologists up to date with the most recent advances. Let us start with our first study, FRESCO 2, which looks at an unmet need for patients with metastatic colorectal cancer that have progressed on multiple lines. Can you please walk us through the study and its findings?
Sure. Fresco 2 was a very exciting study for us because, as you stated, we have a very low bar when it comes to refractory metastatic colorectal cancer patients. This was an important study because it's really looking at a patient population that's all comer, so it's not necessarily specific to a biomarker cohort, and is looking at patients who have progressed on pretty much all standard FDA-approved therapies, including progression on or intolerance to TAS-102 or regorafenib. So in this patient population, patients were randomized 2-1 to receive a novel oral VEGF tyrosine kinase inhibitor known as fruquintinib versus placebo. These patients had to have progressed on the standard chemos, which included 5-fluoropyrimidine-based treatments, as well as oxaliplatin irinotecan. And then, of course, based on their biomarkers, if they were eligible for anti-EGFR therapy and or BRAF treatment or immunotherapy, they needed to have basically progressed on all available treatments. Patients were then randomized to receive what is essentially a daily pill, 3 weeks on, 1 week off, versus the placebo drug. And in these patients, the primary endpoint of this study was really looking at overall survival. I think this was a notably exciting Kaplan-Meier curve in terms of OS benefit. You can see very clearly that the Kaplan-Meier curves separate quite quickly. And so the addition of fruquintinib to best supportive care versus placebo significantly improves median overall survival with a numerical difference of up to 7.4 months and a hazard ratio that's really quite striking. So what's exciting to me is that this was not a questionable, maybe slightly statistically significant benefit. This was a notable benefit in survival. Similarly, we see the same thing in progression-free survival. So the use of fruquintinib significantly improved progression-free survival with a near doubling of PFS in this patient population. And again, I think it's important to notice that these curves separate and basically stay separated, with most patients who are on the placebo arm unfortunately progressing obviously rather quickly, but the fruquintinib arm really being a little bit more of a lag there. So to me, this is a really important study. I would anticipate that fruquintinib will be FDA approved for our patients who are refractory to all standard therapies in metastatic colorectal cancer. And so hopefully we will have a new drug available for all comers. And I think that's the really important aspect of this is in recent years, we've had FDA approvals, but those FDA approvals have been in subsets and cohorts. They're biomarker related therapies. And so in this drug, hopefully we have a new therapy that's really available to all of our patients, which is obviously of incredible value.
Dr. Shroff, as we wait for the FDA approval, given the PFS and OS data outside clinical trial today, would you offer this drug to your patients if need be?
I would. The safety profile, it was a manageable drug. And again, I'll be honest, regorafenib, TAS-102, those are drugs. And so I would absolutely offer this to my patient if I had the ability to.
Perfect. Thank you for sharing your thoughts on that. We can now focus on our second study, the Niche 2 study presented by Dr. Shalabi. The focus here was on patients with colon cancer with microsatellite instability receiving immunotherapy. We saw a similar study for rectal cancer at ASCO 2022. Dr. Shroff, can you please go over the design and the findings of the Niche 2 study?
Sure. This was, I think, probably one of the most exciting data that came out of ESMO, regardless of what disease type you treat. So the NICHE-2 study was, as you mentioned, in a locally advanced and non-metastatic mismatch repair deficient colorectal cancer population. And this is basically a proof of principle of looking at the approach of neoadjuvant immune checkpoint blockade in patients who have microsatellite instability high tumors. Like you mentioned at ASCO, we saw that this was potentially a paradigm-changing approach with the CIRSEC data that looked at 12 to 14, depending on numbers, of patients who had received neoadjuvant immunotherapy. But this study is impressive because it's a larger number of patients. So a total of 112 patients were treated in this study, and they were treated to receive 1 dose of ipilimumab and then 2 doses of nivolumab within a 6-week window prior to undergoing surgery. And the co-primary endpoints were really safety in the intention to treat population and then 3-year disease-free survival. The data that was presented at ESMO is really kind of looking at the early signs of efficacy. We don't yet have the final 3-year DFS. But in the population that was subjected to this analysis it was 107 patients, and most of the patients were stage 3 or high risk stage 3 and had a large proportion of T4 tumors. So these were really high risk patients. So with a median time from first dose to surgery of 5 weeks, what was truly impressive is that there was a pathologic response noted in 99% of patients and a major pathologic response in 95% of patients. And they defined major pathologic response as less than or equal to 10% residual viable tumor in the surgical specimen. So we are talking about patients who literally had minimal residual disease after just 2 doses of nivolumab and a priming with ipilimumab. The pathologic complete response rate was 67%. And the now famous Chalabi plot, I think, is what I think is most striking in terms of just seeing the incredibly dramatic benefit that most patients really felt from this approach. So to me, I think what is incredible about this is that we now have 2 sequential studies that are basically suggesting that we need to be treating MSI high colorectal cancer patients who have a potential for curative therapy differently. And that the earlier introduction or even in early stage patients of immunotherapy is absolutely imperative in terms of potential for cure. And I think as we understand the 3-year DFS from this study, hopefully we will understand the longevity and impact of the treatment. But I think what also this opens up is the question of if you have 99% of patients responding with a major pathologic response and 95% and 67% having a pathologic complete response, can we start thinking through organ sparing approaches? And maybe are there non-surgical approaches that we could be taking with these patients, which is what the study out of MSK suggested. And I think this is continuing to further support.
Wow, certainly a showstopper study. Do you think this is ready for prime time at this point in time?
That's such a great question. I mean, I will tell you that if I have an MSI high colorectal cancer patient, I am absolutely going to give them neoadjuvant immunotherapy. Now, whether or not we have enough robust long-term follow-up to really understand whether A, these patients can avoid surgery altogether, or B, what that disease-free survival looks like after surgery, I think those are the questions that remain. But I think there's clearly a place for immunotherapy in the neoadjuvant space in these MSI high patients. And I think that we even have data that suggests that there could be a role for immunotherapy in MMR proficient patients as well. And so I think that's an evolving space. And as we start to understand that better, hopefully we'll have a role for immunotherapy across the board in neoadjuvant approaches to colorectal cancer.
Certainly. Also, not the same patient population, but if in patients with very extensive tumor burden and MSI high state, though we do offer IO upfront, but do you see any role of sequential approach to decrease the tumor burden with chemo first and then followed by IO?
I think that's hard to really argue now in an MSI high patient population, given that if you look at this plot, we were talking about 6 weeks in which patients saw such dramatic benefit. So could you offer debulking chemotherapy? Potentially, but with response rates in the 45 to 50% versus what looks like complete path CR in 67%, And again, in a shorter time span of only 6 weeks of that neoadjuvant window, I actually think that it's probably reasonable to just proceed with a non-chemotherapy approach in the MSI high population. Again, acknowledging that we need more numbers and more data and more long-term follow-up.
Certainly. Thank you, Dr. Shroff. Now let us switch our focus towards unresectable or advanced hepatocellular cancer. In the Rational 301 study, a single agent IO was compared to sorafenib and was non-inferior. Can you please walk us through the study?
Sure. So this was a study that basically was asking a question that we have asked a number of times when it comes to newly diagnosed unresectable hepatocellular carcinoma who have good Child-Pugh status, Child-Pugh A, and good performance status. Now, in the States, we now know that atezolizumab and bevacizumab is our standard approach, at least in patients who can tolerate it. But that was compared to sorafenib, and there are some patients in whom we are wondering whether or not there's a potential role for single agent immune checkpoint blockade. So this study basically looked at patients and randomized them 1-to-1 between sorafenib, 400 milligrams POBID, our standard approach, versus tislelizumab, which is again, checkpoint inhibitor. And this is given IV every 3 weeks. In this study, there was a question of trying to understand whether or not we could just continue to use this approach with checkpoint inhibition and whether or not it was non-inferior to sorafenib. So this was not necessarily only looking at superiority, but was also looking at non-inferiority. So when you look at the actual stats and the final analysis, the tislelizumab arm showed non-inferiority in overall survival versus sorafenib, but superiority was not met. And so the median OS was 15.9 months versus 14.1 months with a p-value of 0.0398. And you can see on the overall survival curves, there is a separation of the curves over time at the 24-month and the 36-month landmark especially. Again, that's typically what we see in patients who are receiving immunotherapy is this separation of curves that is a little bit more slow, but a little bit more prolonged and lasting. And so the suggestion here is that there is a role for single agent checkpoint inhibition as a non-inferior option to sorafenib. Now, when you look at trying to understand where this falls into the potential treatment armamentarium, I think the presentation at ESMO did a really good job of helping us kind of think through aggressive versus less aggressive regimens. And when you think through that, obviously the aggressive regimens are those that are more combination approaches, like the atezolizumab, bevacizumab, as well as based on the Himalaya data, the STRIDE regimen of durvalumab and a dose of tremelimumab. But then there are patients that we look at who we don't necessarily feel comfortable with combination approaches. And so there has been data based on keynote studies that suggests that pembrolizumab could be considered, or historically we had nivolumab as an option, even though that was subsequently pulled by the FDA. Now with Rationale 301, we have the potential role for tislelizumab demonstrating its non-inferiority to a sorafenib approach. I think the patients in whom a single agent anti-PD-1 or PD-L1 could be considered are absolutely the patients who have marginal performance status, a little bit more borderline hepatic function, older patients. And then there are patients who just cannot receive bevacizumab. I unfortunately see these patients in my practice. These are patients who you do an endoscopy and they have varices that are at risk for bleeding, or they have proteinuria already, and the bevacizumab will only aggravate this. And so to me, the Rationale 301 really makes us feel comfortable that we could potentially have an option that is an immune therapy approach without the additional combination approaches that may require the use of a bevacizumab, for instance. So while it's not necessarily paradigm shifting, I think it adds another tool to our toolbox and allows us to feel more comfortable in considering single agent immunotherapy in a specific group of patients.
And I think it's also important to bring up that during ESMO 2022, pembro-lenvatinib combination data was also presented in first line, and that did not meet its primary endpoint. So though atezo-bev ends up being a common regimen that we'll be using in some selected patients, this might be an treatment option.
Absolutely. Yeah, I think the LEAP-002 data just kind of further amplifies the fact that a TKI VEGF with an IO combination between that and the cosmic data, I think we've kind of got to accept the fact that that may not be the best approach. But I absolutely agree that immunotherapy is here to stay in the HCC patient population, and it's just a question of whether you do combinations versus single agent.
Well, Dr. Shroff, thank you so much for taking the time to discuss these practice-changing studies with us today. We hope that our community medical oncologists will get a chance to incorporate all this data into their daily practices. So thank you so much again for your time.
Thanks so much for having me.